Good afternoon, everyone. My name is Yuthika Naidu. I'm the market access lead for a region we refer to as Southeast Africa with Abbott Rapid Diagnostics. And it's my pleasure today to moderate our session in collaboration with ASLM. Before we commence, I do urge you to please share your name, the country or organization that you're joining us from, and your email address in the chat box so that we can get to know each of our participants a little bit better. So good morning, good afternoon, and good evening, depending on where you're based and where you're joining us from. And welcome to a transformative session where we'll be addressing one of the most pressing health challenges currently, and that's viral hepatitis. So today we stand at a pivotal moment with the power to alter the course of this global epidemic through the adoption of the recently updated WHO guidelines and the strategic use of those diagnostic tools that are available. But despite the staggering statistics, we know that there's approximately 250 million people who are currently living with chronic hepatitis B. And unfortunately, the WHO African region experiences the brunt of that burden, but there is hope. The goal to eliminate hepatitis B by 2030 is ambitious, but it is achievable. At the moment, the current efforts are falling short, with only 13% of those affected diagnosed and 3% treated in 2022. But our session today is not just about understanding these challenges that we're being faced with in Africa. It's about overcoming them. We'll explore how to scale up testing and treatment, simplify the treatment criteria, and improve the care pathways. The new WHO guidelines are basically our roadmap. We're focusing on expanding treatment criteria for all and improving diagnostics for hepatitis B. So today we're honored to host two very esteemed experts in the field of hepatitis. We've got Professor Mark Sonderup, who will commence our session by presenting the updated WHO hepatitis guidelines, offering his invaluable insights into their implications for healthcare professionals. Our second speaker today is Dr. Janvier, who will share his practical experiences and the strides that are being made in the implementation of the new WHO guidelines in Rwanda. And he'll be able to provide us with a real world perspective on the guidelines' impact and its effectiveness. So during the session, please, if you have any questions throughout the session, just type it into the chat box and we'll address them during the Q&A portion of the webinar. So without further ado, let me introduce our first speaker, Professor Mark Sonderup. So Professor Sonderup is an alumnus of the prestigious University of Cape Town. He's distinguished himself in the medical field with his comprehensive postgraduate training at both the University of Cape Town and the renowned Chris Hospital. In 2022, he completed his training, setting the stage for a remarkable career in hepatology. Following his formal education, Professor Sonderup embarked on an intensive 2-year fellowship in hepatology at the UCT Medical Research Council for Liver Research Center. His time at the liver clinic at Chris in Cape Town was marked by significant advancements in liver disease research and patient care. Currently, he holds the esteemed position of full professor in the Department of Medicine and serves as the acting head of the Division of Hepatology. His research interests are both broad and profound, encompassing viral hepatitis, HIV-associated liver disease, and drug-induced liver injuries. Professor Sonderup's contributions to the field are not only academic, with numerous publications in high-impact peer-reviewed journals, but also deeply impactful as he continues to shape the future of hepatology through his dedication to research and education. Over to you, Prof.
Yuthika, thank you very much for that kind introduction. I think you made me feel 20 years younger there because I think you inadvertently said 2022, and I think you meant 2002. But if it's 2022, it's made me 20 years younger, which is fantastic. So thank you for that. Colleagues, good afternoon. And Francis, thank you very much as well for co-moderating this afternoon. And as Yuthika said, I'm going to be looking at issues around how the new guidance from the WHO, in fact, just impacts upon us. The reality is that these guidance changes are extraordinarily important for Africa, because they are geared fully towards a continent that we now understand, in fact, shoulders the burden of viral hepatitis globally. So this afternoon, in the shadow of the recent World Hepatitis Day on the 28th of July, let's just remind everybody that, as I said, about 65 million people in sub-Saharan Africa, WHO Afro area, that in fact are chronically infected with hepatitis B, making up just under 260 million people worldwide. The problem is encapsulated simply in this diagram, in that if you look in 2002, of the 250 odd million people globally infected with chronic hepatitis B, the reality is the vast majority, in fact, were not diagnosed, and even fewer, in fact, were treated. And if we just focus down on this area, which is the African region, you can see how poorly we, in fact, are doing. So if we look at, if we look at those numbers a bit more intently, and this is from the very recent WHO Global Hepatitis Report, one can see, as I said, about 65 million people chronically infected. The problem is we are well under 5%, in fact, diagnosed, and we've got an absolute fractional amount of those people who, in fact, are diagnosed actually on treatment. So we really are behind the curve, and we really do have our work cut out for us if we are going to tackle the scourge of chronic viral hepatitis in Africa. So let's kick off by talking about Mr. LZ. This is a very typical patient we see regularly. He's 38 years old. He is a first-time blood donor, and that's when he actually goes, gets his first donation, he gets screened, and he gets a letter that says, "Dear John, you have chronic viral hepatitis B." So he was surface antigen positive. He was nuclear acid test positive, which is the pan-NAT that most blood services do. He tested HIV and Hep C negative. He's a chap with 2 children. He's married. They are aged 10 and 6. He sort of uses a bit of minimal social alcohol. He's a non-smoker. Clinical exams quite normal, but he does have an increased body mass index of 32. So gets referred. Numbers just briefly, and just remember that we're talking about total bilirubin urine micromole per liter, so it's not jaundiced. His transaminases are fractionally above the upper limit of normal for the laboratory range. White cell count reasonable, platelets sitting at 187, INR well preserved, and an HbA1 screen showed that it's slightly elevated at 6.4%, not making the criteria for frank diabetes, but clearly somebody whose body mass index is starting to reflect a bit of metabolic syndrome, and an alpha-fetoprotein that is fractionally elevated. So drilling down a bit more, we knew that he was HIV negative. He's got previous hepatitis A, immunity. Hep C was negative. He's E antigen negative, and a viral load of 1,745 international units. Has an ultrasound, suggests the liver normal span. There is increased echogenicity, or it's a trigger suggesting whether somebody may have a bit of underlying steatosis, no mass lesions, no ascites. So really a kind of patient that probably is a very typical person who would be detected for the first time as having undiagnosed chronic hepatitis B virus infection. So if we look at guidance and we look backwards, there are multi-society guidance documents available, including the WHO 2015 guidance. And if you look at all of them, they ultimately actually come down to a few simple issues in terms of why we have guidance. We want to improve quality of life, and we want to improve outcomes by preventing the complications of chronic hepatitis B. namely progressive liver disease, end-stage liver disease, and the dreaded hepatocellular carcinoma, or HCC. So that's really the aim of care, irrespective of which guidance you actually look at. To understand all guidance, remind ourselves about the chronic natural history, at least the natural history of chronic hepatitis B virus infection. Post-initial exposure, which of course in Africa is predominant child-to-child acquisition between the ages of 6 months and 5 years, followed then by mother-to-child transmission, and very infrequently adult-acquired hepatitis B. So most people exposed in childhood, exposure happens there. You have these various phases that develop throughout the history of chronic infection. If one looks at it from an immune perspective, it depends exactly what the virus is doing and what your immune system is doing in response. And we determine the phase of infection by looking at ALT and the level of HBV DNA. So we always had those defined perspectives about the natural history: immune tolerant, immune clearance, immune control, immune reactive. And then over the last few years, slightly different perspective on things in that, really the natural history is not as siloed and defined as that, but can be looked at maybe in a sub-way as there are inflammatory times of hepatitis B within its natural history and non-inflammatory periods in the natural history. And putting all that together, and you look at the natural history, what we had traditionally, the way we look at it is look at those phases in the natural history, and within those phases you either have evidence of infection or hepatitis. If you infection, your ALT tends to be normal. Hepatitis, your ALT is elevated. And we looked at those areas. There were two compelling periods within the natural history, namely typically the immune clearance phase, where there's significant hepatitis, highish viral load, elevated ALT, or that e antigen negative phase, where there's also elevating or rising viral load and increased ALT. And those were the traditionally two compelling areas that you would say this person has to be treated. And if you take all of that and you put it into whichever society we had, whether it's EASL, the American Association, or even the Asian Pacific, then we had E positive, E negative, ALT, and HBV DNA that really guided you on when to initiate therapy. So if we look at the philosophy of these guidance documents, it is really you find a reason to treat somebody, and it has to be compelling. Otherwise, you monitor. From a mother-to-child transmission prevention point of view, most societies came out with iterations of recommendations. It was really based on HBV viral load. It had to document the viral load to be above 200,000. E antigen positive, often in many of those situations, sometimes negative, but that was not a determinant. It was the viral load, and you initiated tenofovir and consolidated prevention of mother-to-child transmission with birth dose vaccination or the use of immunoglobulin and then follow-up vaccination. So if you look at the HBV guidance, we go back to 2015, and you look at the WHO perspectives on things, it followed a simpler kind of iteration. Define the patient, look for the viral load, look for compelling indications for treatment. The WHO guidance also separated people back in 2015 into less than 30 or more than 30 in terms of risk stratification. And then the mother-to-child transmission guidance that was updated in 2020 followed similar principles of looking at a level of 200,000 HBV DNA as the compelling benchmark into which to introduce tenofovir in the second trimester of pregnancy. But clearly in all of this guidance, there was already this thinking that, remember, there are people who've got barely elevated ALT levels. You need to look at them a bit more intently. Do they have histories of HCC? Is there family history? Have you looked at the presence for liver disease? People who have low levels of viremia and compensated cirrhosis definitely should have been treated. That was the guidance. Decompensated cirrhosis, you always treat. And then this group of people who've got typically e antigen positive, very high HBV DNA levels, but normal ALT. Look at them and decide whether you should treat as an individualized approach. So already in the guidance back in 2018 from ASLD in this instance, there are these suggestions given that you need to stratify for individuals. In the interim, there's been a lot of pressure from civil society. Groups such as the World Hepatitis Alliance and other groupings have really started putting pressure and saying, but these guidances are too restrictive. We're trying to decide exactly who should get treatment, okay? And therefore the entry point into who actually accesses care is too restrictive. And there was a good editorial earlier this year really saying that a call for action, and a call even more recently of saying, let's treat everybody with hepatitis B. So what was the need for updated WHO guidance? Well, there were clearly major gaps in testing and treatment uptake. The guidelines were quite complex. There are regional differences in demographics, epidemiology. There's a lot of new evidence emerging, access challenges. And so the response to this was, look at what should we do? Expand, simplify care. We should look at issues around the fact that in places such as Africa, disease and complications occur at a much younger age. So this idea of having 30 as a cutoff, as in the old guidance, was really something that was really not appropriate for Africa. And the longer you sit with levels of viremia, the more DNA intercalation you get and the greater the risk of oncogenicity. So there were really a large number of compelling indications to try and foment a new approach. And remember just a couple of pointers. WHO guidance is not for generally high-income countries. It actually focuses and is focused towards low and middle-income countries. And so when we look at that, it's important to understand where the focus of the new guidance comes from. I must just say, I want to just leave a point here. ASLD, EASL, and other groupings are busy working on updated guidance. And one must actually make the point that is it not time that we start harmonizing HPV guidance across the globe, rather than having these rather siloed individual approaches for different regions? So what are the key aspects? Well, the key aspects is that we've gone for simplification of assessment of liver disease, simplifying diagnosis, delivery of care. We've gone for introducing the new data on who to treat, how to treat, and looked at PMTCT aspects. So the first major change is non-invasive assessment replaces liver biopsy absolutely upfront. There is no need indication for liver biopsy to assess liver disease. And we've simplified it. You can use either the APRI score or transient elastography if you have fibrous scanning available. And what you want to try and uncover is whether there's evidence of significant fibrosis. Anything more than F2 fibrosis, as defined by an APRI greater than 0.5 or a kilopascal score on liver stiffness measurement of more than 7. And any evidence of cirrhosis needs to be determined. You can do that clinically, or an APRI more than 1, or a transient elastography score more than 12.5. What about testing? First of all, surface antigen testing. You can use an in vitro diagnostic test, but rapid diagnostic tests that meet minimum performance standards are absolutely acceptable. And there's good evidence for point-of-care RDTs. 15 studies were included in the data underpinning these new guidance. Secondly, point-of-care HPV DNA has been clearly stated can be used as an alternative approach to laboratory-based testing. And thirdly, the suggestion that in fact, maybe within a laboratory-based system or clinic-based system, that people who are surface antigen positive reflexively should have HPV DNA in fact done as well, so that the clinician at the other end of patient care can maximize the data they have to determine eligibility for treatment rapidly and link the patient to care. So what have we said? What has changed? Well, firstly, you simply say to yourself, is there evidence of significant fibrosis based on an APRI or a VCT? That's not difficult. APRI requires an AST and a platelet count. That should pick up at least 20 to 25% of people who are surface antigen positive. And if there's evidence of advanced fibrosis based on these APRI and FibroScan score, it doesn't matter what the DNA and ALT level is. Next, if you have an elevated viral load above 2,000 and your ALT is above the upper limit of normal, the cutoff for normal is 30 for men, 19 for women. Thirdly, if you have any evidence of co-infection, so that's HIV, Hep D, Hep C, if you have a family history of liver cancer, if you have any other comorbidities such as steatotic liver disease or any extrahepatic manifestations, that's a compelling indication, regardless here of the APRI score, DNA, or ALT levels. And if you don't have evidence to HBV DNA, a persistently abnormal ALT level, that's simply 2 levels above the upper limit of normal over a 6 to 12-month period, is compelling indication, again, for treatment, regardless of APRI. So if you look at all of this, you can see how care is being expanded. And we now should pick up and access at least 50% of people who are surface antigen positive would actually meet one or more of those criteria. In terms of treatment, the recommendations are, as before, tenofovir or entecavir. But importantly, what has been added is that many parts of Africa where tenofovir and entecavir are not available, PrEP is available. So tenofovir and emtricitabine combination is available as part of HIV PrEP in programs. And if people can access that who are Hep B mono-infected, they should. What about mother-to-child transmission? Yeah, simplification. It's prophylaxis with tenofovir if you're surface antigen positive and your DNA is above 200,000. That was clear. It was like it was in the past. But where you don't have HBV DNA and even e-antigen testing is not available, if you surface antigen positive and HIV negative and woman wants to access care and try and get PMTCT done, putting them on tenofovir on the basis of a surface antigen rapid diagnostic test, for example, is perfectly okay. I'm just going to move quickly because this issue is really a talk on its own. The guidance has also included the need for hepatitis delta testing should be based on serological testing. And if you don't have it universally available, it should be prioritized to certain populations. So what we've seen from 2015 to what we have now is a rapid expansion, simplification, and we really should be capturing at least half of all surface antigen positive people. Provisions are made for simplification of care and rapid linkage to care. So back to our patient, 38 years old, BMI is 32, his ultrasound suggesting some steatosis, his ALT is well above 30, but his viral load is low. On a multiplicity of situations, if we look at the guidance, he warrants linkage to care. He needs access to tenofovir. So this is a patient who's got an APRI score of 0.6. FibroScan was done at 7.8. And so if we look at this chap on the basis of 2 compelling indications in the guidance, he warrants therapy. Started on tenofovir. We mustn't forget about the fact that the chap's got steatosis. Look at his cholesterol. Does he warrant a statin? Advise and counsel strongly about weight loss, lifestyle, diet. We also need to link patients to HCC surveillance. And then don't forget about his partner, his wife. Make sure she gets screened, linked to vaccination if needs be, and make sure the children, in fact, were appropriately accessed to their Hep B, their appropriate vaccine schedule. So to finish off, if we actually do this and we get this linkage happening, the modeling suggests that by 2050, we can potentially avert 9.5 million new cases of hepatitis B. we can avert 2.1 million cases of hepatocellular carcinoma and just under 3 million lives saved. And I think on that note, I've got to say our work is cut out for us, but it's time for action, and it's time that we actually move forward. Thank you very much.
Thank you so much, Prof. Sonderup, for that very concise breakdown of the WHO updates. And there's a clear demonstration of a focus on improving testing and treatment cascades, simplifying that treatment criteria, and improving those hepatitis care pathways. So we're hoping that that helps scale up a lot of the programs across Africa. Our second speaker, Dr. Janvier, can you start sharing your screen in the interim while I do your introduction? And once again, please, if there's any questions, please do type it into the chat box and we'll address it during the Q&A session. So our second speaker is Dr. Janvier Siramundo, who's a medical doctor with a remarkable educational background, holding not one, but two master's degrees in public health and transfusion medicine from the esteemed University of Liège in Belgium. His 17-year tenure in health leadership roles within Rwanda has been marked by significant contributions to the medical field. As an international public health consultant, Dr. Janvier's expertise span a wide range of critical areas, including research, strategic document development, and ISO-based accreditation processes. His skills in crafting strategic plans, policies, guidelines, and procedures have been instrumental in advancing public health initiatives. Currently, Dr. Janvier serves as the Director of Sexually Transmitted Infections and Other Bloodborne Infections Unit at the Rwanda Biomedical Center, a role that he's had for quite some time, since 2017. His active involvement in hepatitis management and elimination is noteworthy, as he's a member of the WHO Hepatitis Guidelines Development Group and the focal person of CDC Africa for hepatitis elimination in Rwanda. His previous role as Director of Quality Assurance and Quality Control Unit at the National Reference Laboratory for 6 years led to the laboratory's accreditation, showcasing his vast experience in laboratory quality management systems and ISO accreditation standards. Dr. Janvier's expertise in transfusion medicine is further enriched by his 2-year directorship of the Blood Transfusion Services Unit in Rwanda, and his international experience gained from the Belgian transfusion services. In addition to his leadership roles, Dr. Janvier has also imparted his knowledge as a university lecturer, and he teaches epidemiology and health system strengthening courses, helping to nurture the next generation of medical professionals. So over to you, Dr. Janvier.
Thank you very much, Yuthika, for a great introduction. I'm humbled about that. Good morning, good afternoon, good evening. I'm glad to be here to present about the current HPV testing strategies and the impact of WHO updated guidelines and its application in Rwanda. I will have 4 parts to discuss. The first one is the background and status of hepatitis program, the HBV testing and elimination progress. The third one will be the new HBV guidelines and the impact on testing and treatment in Rwanda. And then the last one will be the conclusion. All kicked off in 2002 with HBV vaccination in children, and it was the pentavalent vaccine. From 2002 to 2014, there has been a long period of lag. And only in 2014, that's when the hepatitis program unit was created under the Ministry of Health. And that's when the development of the new hepatitis guidelines for hepatitis B and C were developed and disseminated to all stakeholders for implementation. From 2015 to 2021, mass screening campaigns and vaccination campaigns have been initiated for hepatitis B and C, and the first round of patients were treated. In 2022, we have been intensifying, optimizing and refining hepatitis B management so that we move forward, so that we move to hepatitis B elimination and validation by the WHO. So this slide shows the progress that has been made in matter of hepatitis testing and treatment. It's been done in different phases. And the first phase was about the screening of high-risk groups in 2016. You can see on the left side, the top corner, these people are high-risk group, and we have people living with HIV, we have female sex workers, MSM, prisoners, and so on. So that was the first round of mass screening campaign. And when we were done with the high-risk groups, we moved on with the mass screening campaign for the general population. So you can see a mass of people on the left bottom corner. This was a mass screening campaign for the general population. It was a huge mass, and they have been sensitized so that they can attend a mass screening campaign in a big number. On the right side, you can see a map of Rwanda, and the red spot across the map are the health centers where hepatitis B services have been decentralized. And down there, you can see nurses in a health center consulting patients as part of the routine services. So we moved from mass screening campaigns to task sharing from doctors to nurses, and decentralization to health centers so that hepatitis services are part of the routine services offered in health facilities. This slide shows the launch of hepatitis C elimination. So you can ask yourself, why am I bringing hepatitis C here? So hepatitis B and C are siblings, and hepatitis B, especially in my country, took advantage of hepatitis C elimination plan, because when we were screening, we always screen both diseases. And when the procurement was initiated, it was initiated for both diseases. Available services for hepatitis B include the prevention, mainly vaccination, but also the awareness, the PMTCT, the post-exposure prophylaxis, the communication for behavior change, the infection control in community, but also in healthcare settings. Then the testing, which include a screening using a rapid diagnostic test, but also a confirmatory testing, a viral test using molecular platforms. Currently, we are using point of care as part of the new HBV guidelines. I will come back to that later. Then the treatment, we are using tenofovir and entecavir. Entecavir for 2 to 11 years old, and tenofovir for 12 years and above. So this is the cascade of care for hepatitis B from 2015 to 2024 today. Roughly, we have been able to screen 5.4 million people at 15 years and above. That age category was part of our elimination process. And about 149,000 have been HBs antigen positive, 17,204 have been confirmed viral load detectable. And then we have initiated on treatment, lifelong treatment, 9,029 people. There is a lag in moving slide. Okay, now I think it's okay, it's fine. Some of the drivers of hepatitis elimination in Rwanda included a strong government involvement and support. So the government of Rwanda was really committed and supported the elimination process. It contributed to the multi-sectoral and partnership engagement to contribute to this great initiative. Also, the community was engaged because we couldn't be able to screen without having people from the community. And then our government negotiated the reduction of the prices with suppliers, and prices were reduced. The cost was reduced so that we were able to procure hepatitis B and C tests and medicines for the population in need. Task shifting and decentralization have been key as well to be able to improve the accessibility of hepatitis services for the entire population. And finally, the zero cost of hepatitis services is paramount, and it allowed an easy access of the entire population to hepatitis testing and treatment services. Now, how about the new guidelines? Prevention. Regarding the child vaccination, we are about to initiate the universal birth dose. Previously, we are doing a targeted birth dose, and we are vaccinating only babies born to infected mothers. In the next 12 months, we will be initiating the universal birth dose. The post-exposure prophylaxis, we will add immunoglobulin to the HPV vaccine that was previously offered. And how about testing? Previously, we were using bigger platforms for the confirmation of positive rapid tests. But currently, we are using point-of-care machines. These machines are smaller machines that are disseminated across all the health facilities in the country. So it's easier to test and treat during a short period. They have improved the accessibility to testing and treatment for the entire population based on the geographical accessibility as they are located in many health facilities. Regarding pregnant women and exposed infants, there is a systematic screening of pregnant women at first and then at delivery 2 times. And when during the delivery, the baby will be vaccinated during the 24 hours of birth. And then for exposed infant, we will add immunoglobulin. And then the follow-up 12 months and 24 months later to decide if the infant will be treated at the age of 2 years. Regarding the co-infection, previously we were considering HIV and HCV as co-infections of HPV, but now with the new guidelines, we have added hepatitis D and we will consider it. Treatment eligibility, we have so many as they have been highlighted during the first presentation, but the most important is the treatment, which will start from 2,000 international unit of viral load per ml of blood. Previously, the cutoff was 20,000 international unit, and the reduction of this cutoff will allow us to treat more patients and with a good outcome of those patients. Now, the follow-up of people with viral load under 2,000, it's just a monitoring of HBV DNA, the viral load, which is done every 6 months. What is the impact of the update of the HBV guidelines, especially in across Rwanda health facilities? There is an increase in testing uptake because there has been an improvement in testing and treatment services in terms of geographical accessibility, but also financial accessibility. There has been a reduction of the result turnaround time. Today, you can just do a rapid test, and once it's positive, you can confirm it with a viral test the same day, and you can initiate the patient on treatment the same day. So it's really interesting. In the past, it was not the same scenario because we had to wait for the viral load result during weeks, and the initiation of treatment was a little bit delayed. So there is a quick initiation of patient to treatment, and this has really improved the overall hepatitis B services. For pregnant women and newborns, as said, there is an emphasis on antenatal care, and then pregnant women are screened twice during the first visit and at the delivery. And then for the babies, we are introducing the universal birth dose in the next future, and we will follow up the kids after 12 and 24 months so that we can initiate treatment at the age of 2 years, if applicable. So in conclusion, a lot has been done in terms of HBV program management. And today we need to sustain HBV elimination achievement and address the remaining gaps. Especially we are focusing on the EMTCT, and we are focusing on data management so that we can strengthen information systems for validation by the WHO. Thank you very much for your attention.
Thank you so much, Dr. Janvier, for sharing those experiences from Rwanda. And I have to say the strides made in the implementation of the recent WHO updates is definitely commendable. And it's also great to see all the effectiveness of the program that it's had in the program. So, ladies and gentlemen, we can now move on to our Q&A session, and it's fantastic to see that we've had so many questions coming into the chat. And please, if there's more questions, don't hesitate to post that in the chat. Thank you to both our speakers for their insightful presentations. And as we transition into this Q&A portion of our webinar, let's delve deeper into the topics we've discussed today. So our first question for today is from Sierra Leone. And the question is, given the WHO's new guidelines on hepatitis B, what specific strategies can be implemented in Sierra Leone to improve diagnostic coverage and treatment accessibility, especially in those rural areas where healthcare infrastructure may be limited? I open this up both to Prof. Sonderup and Dr. Janvier.
Yuthika, maybe let me just have a stab at it first of all. Well, I mean, I think that there are things in life when you don't have to reinvent the wheel, as they say. And I think Janvier has shown us what happens when you actually have the desire, the will, and most importantly, the support of those those in government, those policymakers to actually implement something. But most importantly, if the question is posed around how does one start, you have to start by firstly acknowledging that there is a problem. You have to then have a clear working plan as to what you're going to actually do. And that therefore boils down to a national strategy or a national elimination plan that one needs to have for your country. And once you have that plan in place and agreed to, you then have to understand how are you going to cost that plan and how are you going to implement it. And that probably requires a combination of both domestic funding, support, and then to look at whether countries can access external funding. And that's where the big challenge is at the moment around viral hepatitis in general. But the reality is that the tools are all there. So, for example, as we've seen and as we've been at pains to reiterate, you don't need high-tech absolutely in place to implement your plans. You can get away with point of care or point of service rapid diagnostic tests. You can still do things. You can still link patients to care. So it's all about what you have available in the kitty and how you're best going to spend that to net the largest number of people you possibly can and then link them to care. But there is an aspect to this I think I would be remiss if I don't mention, and that is you also have to have buy-in from communities themselves and understand what is being done and why it's being done. Because unless you have the buy-in from communities and people, then whatever you're doing at your end is probably never really going to fly. It needs to be a conjoint effort. So along with any strategy or plan has to go simultaneously issues around education, getting people understanding what's being done. And I think that is something that Dr. Seramondo can speak to, because I think Rwanda has been superb about that, of getting actually people to understand and getting community buy-in. So that is a really broad brushstroke to a very complex question, but a very important question, because that is exactly what we need to do. How do we do this?
Over to you, Dr. Janvier, if there's any additional comments you'd like to make to that question.
Yeah, thank you very much, Yuthika. And I think the first speaker has greatly addressed the question, but I can just add some input. So the first thing is just the government commitment. So when the government is committed, there is a negotiation about the prices of tests and medicines, and then they are procured at a very low price. That's the first thing. So the prices are very low, and then the accessibility starts from there. And when you have the tests and medicines in country, then you can move on with the next steps. So rapid tests are usually not expensive, and then you can disseminate across the country, and then the population can be screened, at least the rapid test. And then the second, so if for hepatitis B, it's not really complicated. It's not like hepatitis C where you are doing an antibody. So when you can screen people for the HBs antigen, even without having a viral test, you can know who are positive, who are not, and with a follow-up, you can know who to treat and who to not treat. And obviously, with a viral test, there is a great improvement, and the best choice is the point of care machines. Currently, we are using gene expert machines, and those are smaller machines, and they are located in so many sites. And it's really great. So when patients come to the health facility, the same day they can benefit from a rapid test, they can benefit from a viral test, and then they have all the results the same day. And they can be treated, initiated on treatment the same day. And it's really an important move. So regarding treatment as well, so the tenofovir is not expensive. Maybe if you don't want TAF, that TAF is more expensive, but tenofovir is not expensive, and it managed to treat a big number of people. And then as you move on, you can introduce entecavir, which is more expensive, but it's not really indicated for a big number of people. It's just for children, and we usually don't have a big number of children who are infected. So that's my humble contribution. Thank you.
Thank you so much, Dr. Janvier and Prof. Sondrup. Our next question, and I think Dr. Janvier, you touched a little bit on this, but one of the listeners mentioned that many countries in sub-Saharan Africa don't do all these tests for hepatitis. So majority of what is done is rapid HBsAg testing, and that's routinely for blood donors only. What's the cost implications for administering all these tests for blood donors and routine work in hospitals?
Yeah, thank you very much once again for I think the cost of one rapid test is less than $1, and maybe you know better than me, because what we are procuring is from abroad currently, and I think so many countries are procuring rapid tests from abroad. So it's the cost is not high, and for blood donors, I think most of the countries are using other tests more than the rapid test, because they need to screen blood bags carefully. And for those who are positive, they can be confirmed and go to the next level of the cascade of care. So coming back up to the cost of rapid tests, I think all the countries can be able to access at least the rapid test, and then they can see the next step, how to access the viral test and so on. Over.
Thank you so much, Dr. Janvier. Our next question comes from Nigeria, and it asks, the participant asks, how can Nigeria adopt this standard besides relying heavily on the government, which might not be capable of achieving this? And hepatitis B profiling is not done in most donor clinics, which needs to be addressed urgently.
Yeah, you think, I mean, that is the core issue, because what the participant is asking is transversal to the entire Africa. Because the reality is that the aim here is elimination, and elimination is entirely achievable. This is the sad reality of the problem, is that we actually have all the tools available. And the tools are actually not complex tools. The diagnostic tools are not complex. We're talking about rapid diagnostic tests. We're talking about potential point of care DNA, or in the case of Hep C, RNA testing. We're talking about medications in the way of hepatitis B that, as Janvier quite clearly has said, can actually be procured and are not costly. Tenofovir is no longer a costly drug. Entecavir may have more cost to it, but it's got a very limited need in certain populations. The price of TAF will come down as well. in time. And so we may be moving towards using more TAF in time instead of TDF. That it's not expensive. The cost of Hep C drugs, for example, has dramatically come down, and with appropriate discussions, those costs can be contained as well. So all the tools are there. What is missing in the entire soup is political will. And that is what Rwanda is clearly demonstrating, is that if the political will is there, it happens. This is not the responsibility of the individual citizen. This is a country and a continental issue. And so it's up to countries, governments, and the continent to actually coordinate its efforts. And it needs to be domestic funding. We can't sit and wait for someone to come along and do this for us. We need to do it ourselves. The costs are not excessively prohibitive. So yes, the individuals or groups or clinic in Nigeria, wherever they are, can introduce this very simply, but it should not be that responsibility of that individual group. It is the responsibility of the Nigerian government, the Department of Health, and the whole sub-region and the continent to actually look towards an elimination plan, procurement of diagnostics, procurement of therapeutics. And so this can be done. That's exactly what happened with HIV. It's exactly what happened with many other diseases that we've managed to conquer. Why do we have this blind spot when it comes to viral hepatitis? And those are the difficult questions we should be asking our leaders. I want to add that on a positive note, I was involved in a World Hepatitis Day forum last week, transcontinental, when there were many parliamentarians from various countries on. And there are champions out there. There are politicians out there from many countries who understand the seriousness of this and are championing this. What we need as a citizenry is on our continent to start telling those who are leaders, take this issue seriously. It's time for action. And with that note, I think I'll get off my soapbox, Yuthika.
Thank you very much, Prof. Sandarup. Unfortunately, we didn't get through all the questions, but we will, if your email addresses have been posted on the chat, we will aim to get the responses to each of you for the questions that were posed. So before we bring the session to a close, and I see we're almost at time, I would like to invite our esteemed speakers for any final remarks. If you have one or two sentences you would like to sum up with. Prof. Sandarup, I will start with you.
Well, I'm going to be very short and just say, again, what I've been saying now many times. It's time for action. It's time to get the job done. It can be done. Yes, we can.
100%. And Dr. Janvier, over to you.
Yeah, thank you very much. So what I would like to say is just what is missing is not the budget. It's just the will. So government need to make it a priority. So if it's a priority, if the hepatitis elimination is a priority, it will be funded. Because there is a fund to build roads and other heavy infrastructure. So we can also have funds to establish hepatitis services. Thank you.
Thank you very much, Dr. Janvier. Absolutely. So, ladies and gentlemen, as we conclude today's session, I'd like to extend our deepest gratitude to our speakers and you, the participants, for your invaluable contributions. We've really delved into the complexities of hepatitis B, even in just this hour. And the discussions today have really highlighted the urgency of our collective mission to eliminate hepatitis B by 2030. I mean, despite the statistics that we've mentioned, we leave the session now armed with the knowledge and tools that are necessary to now turn the tide. And the new WHO guidelines and updates offer a beacon of hope towards providing a simplified and expanded framework for treatment and diagnostics. So thank you once again for your dedication and your commitment to this cause. And may the momentum that we've built here today may just propel us into the future where hepatitis B is no longer a burden on the health of millions in Africa. So thank you to ASLM for bringing us all together today, and let us continue this vital work with shared resolve. Thank you, everybody. Have a wonderful rest of your day.
Thank you, Yuthika. Thank you, everyone.